the business case for quality improvement. My name's Amar. I'm a forensic psychiatrist and Chief Quality Officer at East London Foundation Trust.
And good afternoon, everybody. My name's James Innes. I'm a pharmacist, and I'm also Associate Director for Quality Improvement.
So, welcome everybody, and thank you for joining us for the next hour. For many of us who work in the world of quality improvement, our life can sometimes feel a bit like this, can't it? Where we are trying to help people see that there might be a better way to think about the challenges that our services are facing today. Trying to offer them a new way to think about solving some of our most complex, high-priority issues today. And in thinking about how do we engage people in trying quality improvement and seeing the value of it, we need to do two things. One, we need to really make sure that our quality improvement is focused on the things that truly matter to those who we are here to serve. So making sure that our improvement work is completely focused on the needs of our population and our patients. And secondly, we have to find a way to show people that quality improvement can tackle the really complex, high-priority issues that are on the minds of our leaders today. And it's that second topic that we're going to spend some time on today. Often it can feel like our efforts to improve quality run completely separate to our efforts to manage cost. Sometimes the way that we go about both sides of this are very different. Sometimes the things we try in improving quality have an effect on cost. Sometimes the things that we're doing to manage cost have an adverse effect on quality. So we need to think about a way to bring these two together. And of course, in more mature quality systems in other industries, there is a single management approach to both of these things. So our task is to think about how do we bring our thinking around using quality improvement to tackle both sides of this equation. For those of us who are at the beginning of our quality improvement journey, we will know that we need some investment up front in order to build the capacity and capability that will then yield results downstream. So how do we make the case for investing in quality improvement? How many of us have had to make that case to our leaders? Can you put your hand up if you've had to, at some point, make a case for investing in quality improvement? So when I had to do the same thing at our organization, it's a difficult case to make. There is not a lot of literature to draw on to demonstrate the return that we're likely to see as an organization from investing in quality improvement. And yet we know it's so critical that we need to invest up front in order to yield return downstream. So I'm hoping that this session today will give us a little bit of a framework to think about how we might do that. So the objectives that James and I are going to try and achieve over the next hour in this session is, first of all, to articulate, through our learning at East London Foundation Trust, a framework to articulate the types of return, the kinds of benefit we might see from quality improvement work. We want to give you some examples to demonstrate this. And then in the final section, we're going to think about how we move from just thinking about quality and cost to now thinking about value. So to start us off, James is going to help us understand where we come from, where we work, and the kinds of improvement work that we've been doing to set the scene for our framework for return on investment.
Thanks, Amar. So let's do a little bit of geography first. So here we have at the top left the southeast of England, and here is London. And we provide services, mental health services, child and adolescent services, and also community health services in three boroughs in central East London: Hackney, Tower Hamlets, and Newham. We also provide forensic services in that area and a far wider area, of London as well. We provide primary care psychological services, not in East London, but another part of London, and some speech and language therapy services in Barnet. And more recently, we've started providing services not in London, but 50 miles north of London in a place called Bedfordshire, a county. And we provide both mental health and community health services there as well. So Amar talked, and I've already seen a show of hands from people really thinking about putting out the business case for doing quality improvement work. And our formal journey really started just over 4 years ago when we launched our quality improvement program in February 2014. And what you see here, this is our own strategy for how we've been doing that. So I'm hoping I'm speaking to most people here who recognize driver diagrams. And on the left is our main aim, which was to provide the highest quality mental health and community health services in England. And what you'll notice straight away is that we're not just focusing on QI projects themselves. We think it's just as important to spend an equal amount of time on encouraging and inspiring people, building improvement skills, and making it part of day-to-day work rather than a separate add-on. So we've done lots of things. There are many, many ways to engage and inspire. One of the first things we did was create a little microsite, qi.elft.nhs.uk. We deliberately made it external, so you could all now, with your phones, log onto that and look at it. We found that very powerful to convey our message, not just to our staff, but to our citizens in the area we are, our patients, students, and everybody like that. We try really, really hard to publish what we're doing. We try really, really hard to celebrate what we're doing as well, because doing quality improvement work is not always easy. So it's very, very important to give people a pat on the back and give them the opportunity to go and celebrate and win national awards and realize what they're doing is really rather special. Central to a lot of our work is building skills around improvements. None of us, healthcare professionals, I think, ever learn about systems thinking or how you improve systems when we're at university. And we're finding that's massively important. So we now have 10 different offerings to train people. All the way from our experts by experience, our service users, families, through to actually working in the local universities, before people even come to us, through to our staff and a range of different options. In the last four or so years, we've trained just under 2,500 people. And this infographic gives you a sense of who uses which course. Our two main courses are one, a thing called Improvement Leaders Program. It's a 6-month deep dive into using QI, focused specifically around projects. So you can't come on the training without having a project. And another one called Pocket QI, which are 2 half-day sessions designed to be very, very accessible and easy for people to get hold of. So it's very, very easy to build will about something and build skills, but without actually making it easy for people to do the right thing and do this as part of their day-to-day work, you'll be in a lot of trouble. This has evolved for us over time, but I like to think of the team in the center. Any team who wants to improve something. This is a clinical team working in a psychiatric intensive care unit, and what we've tried to do is build around them a structure to help them move forward. So every project has a sponsor. A sponsor doesn't have to be an expert in quality improvement, but what they are is somebody senior who can champion the cause and break down barriers. We've also invested in training around about 80 coaches now in the organisation. Once again, there'll be clinicians or normal members of staff, managers who have got ring-fenced time just to support QI projects in the organisation. And we found that has made a massive difference. We've got a small central team who are there to help with higher priority areas. We've tried to set up forums at each of our 10 different services to really be a place to champion what's going on, to support projects and to help them move forward. We couldn't do this without our service users. Our experts by experience, they are absolutely pivotal in this. And by having a service user there, the results we get are far greater than without having them there. So we work very, very hard to involve them. And finally, we've got lots of resources, whether it's using new and innovative systems like Life QI, so people can do their driver diagrams and their run charts and everything online, through to using dashboards to help people see information real time. So in total, over these first 4 years of our program, we've had 222 projects. At the moment, 140 are active, and 82 have now done what they needed to do. They've achieved their results, and they've completed. But it's a great situation where, and I think this sets the context for thinking about value for money and a return on investment. We have 116 projects that have shown and are showing demonstrable results, showing improvement. So the question really has to be, on that basis and on that context, how do we show a return on investment and how do we think about value for money? Amar.
So from the last 4 years of work that James has very neatly condensed into 5 minutes for us, I'm going to try and articulate how we think about describing the benefits we see from quality improvement. And this has not come in isolation. There has been plenty of work in this field trying to describe to people, based on evidence, what is the link between quality improvement and how do we make the business case? What's the effect on cost from doing quality improvement work? From this Health Foundation paper to the white paper from Wales to the IHI white paper, which came out almost a decade ago now. And the one that I drew most of my knowledge from when I was writing our own business case, which is Steve Svensson's paper on the business case for quality improvement. But I'm going to start with Noriaki Kano in thinking about how to articulate the business case. Kano is the professor emeritus at the University of Tokyo, and he, amongst many things that he has done in thinking about quality management, he's helped us understand that there are 3 kinds of things we should be thinking about through our quality work. First of all, can we eliminate the quality problems that arise because customers' expectations are not met? Secondly, he's described, can we use quality improvement to reduce cost significantly whilst maintaining or even potentially improving quality? And thirdly, he's described the opportunity to expand the expectations of our customers by providing products and services that are unusually high in value. And Steve Svensson's business case paper thinks about 4 different aspects. He talks about the benefits being around improving what we offer to our patients, so meeting the needs of patients much better. It talks about the effect on organizational reputation. He describes what he terms esprit de corps, which is how we feel about ourselves and the people we're working with, and this notion of joy, which we're thinking about now around joy in work. And the 4th thing he describes is the benefit around having sufficient financial return in order to reinvest back into your medical practices so you can make sure they are state-of-the-art. So Svensson describes 4 key planks in thinking about the benefits we might see from quality improvement. And I think that's a fantastic framework for us to draw on. What we've tried to do in our framework for understanding return on investment is translate some of that into the English healthcare economy and how we think about cost particularly and the opportunities that exist for us in our healthcare economy. And so here it is. The framework that we are trying to describe for describing the return that we are likely to see from quality improvement efforts. And you'll see that there are 6 levels here that we are describing rather than the 4 that we see in Svensson's paper. And what I'd like to do now is take you through each of these 6 different types of return and give you some examples of this. Because I think this is, for me now, the way that I try to describe what impact we are seeing from quality improvement. And how do I demonstrate to people that this is delivering value to the organization in multiple different ways. You'll see here that cost only features, the word cost only features in 2 of the levels, which is important, and we'll come back to this. So the very first level of return, and the most important level of return from this kind of work, has to be about improving the experience and outcomes for those that we are here to serve. When many people think about a business case, they automatically think about money, and yet this is the real reason for doing quality improvement work. most of our improvement activity needs to be focused on meeting the needs of the people who are in contact with our services or who need our services. And so articulating that this kind of work is actually going to help us achieve this purpose is really important. Now, this is also the core purpose for almost all of our organizations. We exist to provide high-quality care or improve the health of the population in which we work. And so this level of return from quality improvement actually aligns completely with the core purpose of our business. And so it's really important that we draw the link. Now, we have many, many examples of quality improvement work which has improved the experience or outcomes for patients, carers, or families, and you will have examples too. I think sometimes we do ourselves a disservice by not including that in the way that we think about the return we're likely to see. So this is one element that's in Steve Svensson's framework and is also in ours because it is such a critical component. It is the main reason for undertaking QI, and it ought to be where the bulk of our improvement activity is designed around. The second aspect of return is around the experience of the people working in the healthcare system, what Steve Svensson described as esprit de corps. And I think there is now a growing degree of belief in the relationship between the use of quality improvement and the experience of people who undertake quality improvement work. So as you start transitioning to become a more continuously improving organization, where the power is flipped and staff have the skills and the permission to be able to tackle complex problems in their unit, where they feel that they have the autonomy to make decisions and have more control over their environment, we are likely to see that people have a better experience. They feel more that they're able to make a difference. And they feel also connected to the purpose of the organization. So quality improvement work is able to help people feel like they have more control over the system in which they work, that they are able to focus on what truly matters to them and to their patients. And really good quality improvement work will make sure that it involves the entire multidisciplinary team and is done in partnership with those who we serve, with our patients. And when we start to do that kind of quality improvement work, we start creating much more cohesive and stronger teams, and we start opening up conversations between caregivers and care receivers, between staff and patients. And when we have that healthy dialogue about what matters most to us and what can we do about it, we start to see people really connect with their intrinsic motivation of why they came into the healthcare business. So this second level of return is really important. And for those of us thinking about the triple aim or the quadruple aim, we know that if we want to improve the health of our populations, improve experience of care, and improve the value that we're seeing from the pounds we put into our healthcare, we have to do that through the vehicle of staff engagement. So being clear that the use of quality improvement will improve the experience of people working in the healthcare system is going to be really key to the business. So this is the second level, and for us, we have seen a similar relationship between the use of quality improvement over time and our staff's experience of working in our organization. So here is our data, and we're the red dots here compared to every other healthcare provider in England. And you can see some relationship over time where the red dot is going in the right direction. It is nowhere near where we would like it to be, and there still remains a lot of variation within our organization. But I think there are more and more examples now of organizations where starting to use quality improvement at scale leads to a better staff experience. And certainly in the English NHS, when we look at the staff survey data that's done annually, we can see a relationship between staff experience and patient experience, and a relationship now between staff experience and financial performance and patient outcomes in the NHS too. The third level of the framework for articulating return on investment is around productivity and efficiency. So here we're thinking about the light green dollars that are described in the IHI white paper, or the soft dollars, as Steve Svensson describes it. Productivity is really about the average output you're likely to see for the resource or cost going in to a process. So here we're thinking about how can we manage our demand better? How can we work differently and do more within the same amount of resource that we have? And this is obviously going to have huge benefit for us as we see demand increase for healthcare across different economies. Lots of our improvement efforts will improve productivity and efficiency. So this is a really important aspect to also describe. Here is an example from a very small service which monitors the use of a high-risk medication in people who have treatment-resistant schizophrenia. So these patients who are on clozapine have to have blood tests done, and their results have to come back to the clinicians to enable them to monitor the use of this high-risk medication. And this is an almost textbook control chart here, where you can see that this service, which used to have high levels of variation and an average turnaround time of around 17 days, has managed to go from high levels of variation to much smaller levels of variation, but also managed to reduce the average time from about 17 days to about 7 days. So this is a service now that is much more stable, much more predictable, able to be more agile and responsive in turning around results. And that is freeing up their time. It's allowing them to see what else they could do and add value as a service. Here's another example now. We've had for the last 2 years, 15 teams out in the community, mental health and community health services, all working to improve flow through the first part of the pathway from referral through to being seen. And these teams have simply used quality improvement to understand their process and improve the process. And you can see from the first chart here that the average waiting time that patients are waiting from being referred to being seen is reducing over time. You can see also that this has been done over the same time period as demand has increased. The number of referrals these services are seeing has gone up at the same time as waiting time has gone down. And that has largely been achieved by being able to engage better with patients. So we're seeing a much reduced level of non-attendance at appointments. So here are 15 services who, given no extra resources, have used quality improvement to engage better with those who are coming into our service, see them faster, and manage an increasing demand with no additional resource. Now that's phenomenal. And this is really about improving productivity and efficiency. This is not going to result in changes to the financial bottom line, but it is going to make these services feel like they have more control over their system, and it is going to free up capacity that they can then think, how might we add value to our service users in a different way with the extra capacity we're releasing? So a number of other examples we have about teams that have managed to improve efficiency and productivity through quality improvement work. And no doubt you will also be able to think now about examples you have in your own organizations where teams have undertaken work to improve experience and outcomes, but have also managed to become more productive and efficient through doing that. So the fourth level now we're going to talk about is cost avoidance. So this is still a soft saving. Here we're talking about how can quality improvement prevent us from incurring costs to the system. So as an example, if we can avoid the incidence of adverse events, we can avoid the cost of having to manage those adverse events. And this is an important activity to help us be more financially sustainable and manage our costs. So cost avoidance, we think, is something slightly different to productivity and efficiency, which is a slightly different level of benefit we're seeing from quality improvement. And let me give you some examples to describe this. In our community, our district nursing service has been able to show that they can reduce the incidence of pressure ulcers. So here you see grade 2 pressure ulcers in our community services reducing over time. What we've been able to do with our clinicians and our finance team coming together is to now look at what is the estimated cost of managing a grade 2 pressure ulcer when it occurs. Now there are obviously staff costs to that, the time and effort and follow-up needed to manage a grade 2 pressure ulcer. But there are also non-pay costs, things like dressings and other kinds of materials you need to manage a pressure ulcer. And so we're able to now say that if we can avoid a certain number of pressure ulcers occurring in our services, we can quantify the costs that we are avoiding having to spend on managing pressure ulcers. So there's cost avoided there, but there are also productivity improvements because you're releasing the staff time from having to manage the adverse effect. So that's one example. Here's another example from our workforce team that has worked for some time now to improve the disciplinary process in our organization. So here is a process that a small number of staff are referred into when there are concerns about their performance. And obviously, this is a really distressing time for the individual and the service when someone goes through this process. But there's also a real cost impact here because that member of staff is usually suspended on full pay while this process is undertaken. And you can see that the average length of time for this process was about 113 days before they underwent the quality improvement work. And very similarly, what our finance team have been able to do with our workforce team is look at how much it is likely to cost for one person to go through a disciplinary process. Looking at the data we have and starting to model the predicted cost for one person to go through a disciplinary process. And as we've been able to reduce the length of time from the start to the very end of the disciplinary process, we can now show that we are managing to avoid a cost to our system of close to £500,000 a year through reducing the length of time that the disciplinary process takes. A couple of other examples now. So here's a piece of work that was undertaken on our older adult mental health wards, where the focus of the work was not about cost. The focus of the work was how can we really improve the safety of the older adult wards and prevent the incidence of violence, which is, you may think, infrequent, but actually much more frequent on our older adult mental health wards than you might imagine. So here are 3 wards that have worked together, and they have managed to go from 3 days between each incident of violence to 8 days between every incident of violence. And another outcome measure that we looked at in this project was days between staff injury due to violence. And you can see that there used to be 8 days between each incident of staff injury due to violence, and they've managed to go to 25 days between each incident of staff injury. Now, you already are probably thinking that is going to have some effect on cost, because every time a member of staff is injured, that means that they will be off the ward for a period of time. They may be off sick for long periods of time, needing recovery and support. And we have to bring in temporary staff. We also may need to bring in additional staff to help manage the patient who was aggressive and violent. So we've been able to, again, bring our older adult clinicians together with our finance team and start understanding the costs related to violence on these units. Start to understand what happens when someone becomes violent. What are the sequelae? How can we estimate a cost for those? And start looking at what are we managing to avoid incurring as we've been able to reduce the incidence of violence. And so that, as an economic model, has been written up in this paper, which you can look at from our website if you're interested. We've done a very similar piece of work on adult mental health wards. And here we've got large numbers of wards now looking at reducing violence. So here's the rate of violence across 6 adult inpatient wards, which you can see has reduced over time. And we've been able to bring our clinicians and our finance team together again to look at the costs of managing an incident of violence, the repair costs to the ward, the legal costs, the medication costs, the costs of extra staff needed to manage that incident. And we can now estimate the costs that we are avoiding having to spend through reducing the incidence of violence. Again, a different model, because it's a different unit with different kinds of response. And that's, again, a publication you can look at on our website. So these 6 wards in Tower Hamlets used to overspend every year on their budget. After doing this work, they are now coming in on budget. So this is relieving cost pressure from our system. It is not contributing to our financial bottom line, but it is avoiding costs being incurred that we were not anticipating. And that allows us to manage what we have a little bit better and not have to face additional cost pressure. So the 5th level is around cost reduction. Now, most people, when they think about articulating a business case, automatically go to this. And you can see that I've spent a long time describing 4 other kinds of return that we see from quality improvement. And that is intentional because quality improvement adds a lot of additional value beyond just reducing cost. But cost reduction is really about now the hard dollar savings that Svensson describes, the dark green dollars from the IHI white paper. This is about removing costs from the system completely and contributing to the financial bottom line. Now, in the English health economy, most providers have to remove about 3 to 5% of their costs from the system every year. And you can see how doing that repeatedly, year after year after year, really becomes quite difficult. So for many of our senior healthcare leaders, removing costs from the system is a real challenge. And so what people often ask is, if you want to undertake quality improvement, how is it going to help me with this challenge? And I would urge you to think about how do you reframe that so that people can see that there are multiple levels of return they're going to see from quality improvement. This is going to be one, but only one kind of return they are likely to realize from quality improvement. Quality improvement should not be undertaken just to realize this level of cost reduction, because there are way more important reasons than just this for quality improvement activity. But cost reduction is important. Let me give you an example of what I mean by cost reduction. So here is a team from one of our older adult mental health wards that tried to make sure that their patients were kept safe and at home instead of needing to be in hospital. So how can we better make sure that we provide support for people at home so they don't need to come in, and when they do come into the ward, they are able to go home safely as soon as possible. So this ward was operating at about 88% occupancy. And after a period of work, testing a number of ideas through PDSA cycles, they managed to reduce that down to 58%. They then took that suite of interventions that they had tried on this ward and took it to their next door ward, where they did a very similar kind of activity and managed to see a similar kind of improvement in reduction in their bed occupancy. So now you have two wards functioning at about 50% bed occupancy, and they managed to go from 2 wards to a single ward. And that allows us to now repurpose that ward we had, or remove that from the system, and realize a cost reduction of about £1 million a year. So that is cost removed entirely from the system, or reinvested in another way, but that is contributing directly to the bottom line for the organization. So I'd suggest you think about how you help people think about the cost impact from quality improvement work. Most of the impacts on cost, certainly from our experience, has been around cost avoidance, not cost reduction. But nevertheless, a small number of projects ought to be able to release cash and remove it entirely from the system. So if you are working at scale, you should be thinking about, within your portfolio of projects, how can you develop a balance so that a small number of them are using quality improvement to target opportunities for cost removal from the system. And it should be a small number within a large portfolio of projects. So for us, we ask every part of our organization to identify opportunities for cost removal and include that within their portfolio of projects that they design using improvement. And we've also helped our finance team to learn new skills around economic modeling, because when you're really trying to understand what are the costs and predict the costs that you might be avoiding or removing, you need a different kind of skill to management accountancy. So our finance team have been retrained and are now helping alongside our clinicians to really understand cost impact from our quality improvement work. So the final level of return, the 6th level here, is about revenue. And in Steve Svensson's paper, and certainly in the US, this is an important aspect of quality improvement work. If you can demonstrate to others that you are a high-quality provider, you can compete for business, you can attract new business and generate revenue. For us in England, it's a much harder business. We are not really able to compete for individual patients. We win large contracts for a large number of years, but the ability to generate revenue is much more limited, I think. Nevertheless, focusing on quality, making that your prime purpose, does lend you organizational reputation and competitive advantage when it comes to bidding for new business. So it will contribute to revenue generation, which is equally important in meeting our operational efficiency targets for each year. The other aspect, which is often under-recognized, is that using quality improvement, the core tenets of quality improvement being setting yourselves a shared goal, using data to demonstrate that you're improving, and making changes and being really agile, those things are much more likely to lead to you retaining business, because you will be able to demonstrate the things that you're doing and the impact that you are having on the community much better if you start using quality improvement, using data, and being agile in the way that you test and learn together with your community. So for us, over time, we've seen our revenue grow, partly, but not entirely, but partly related to our efforts to become much more of a quality organization and the competitive advantages that brings to us when we're looking to grow as an organization. So I've walked you through the 6 levels of the framework that we're proposing to think about the return on investment from quality improvement. I'm now going to turn to James to help us think about where we're going to take this next as an organization.
And that's a great provocation, because we've started introducing you to the organization, and we've talked through the fact we've got 220 projects, many seeing improvements now. We've also demonstrated there's many ways you can demonstrate your return on investment. But one of our issues is, rather than just looking at the side effects of the projects and whether they do demonstrate a return on investment, we are working in an English health service where we are having to make year-on-year cuts of around about 5%. So this got us thinking, can we use the QI approach to be far more purposeful, to actually think about, can we identify projects where we can use a QI methodology to bring cost out? So that's what our next proposition is. Can we use this approach and be far more purposeful to find things? So we tried to go about it in our own way. And we're going to show you, in a sense, 2 PDSAs that we've trialed. And we just want to share this with you and show you how we've done that. So our first approach was taking a lot of the stuff out of Don Abedian, looking at structure and process and outcome. So we set up an aim. We wanted to think about reducing non-pay costs in the organization. The first way was what we've already described, continuing to identify emerging QI projects. All our projects are identified ground up from our staff. So when we see projects that potentially could demonstrate adding value, we'll link our finance team in with them, we'll link others in with them and try to understand what's going on. But could we proactively start to identify and create a portfolio of new high-impact projects that could give us these reductions, cost reductions? So that was the how, and what we then did is we set up a structure to try to deliver that. So we created something called a Value for Money project board. Our chief financial officer chaired this, and we had that linking directly to our other QI structures in the organization. We linked in improvement advisors, IHI trained improvement advisors, and we had project teams working. So we took a typical approach that you'd use for any QI project. We started thinking, where do we go? Where would we actually target to start off with? And we thought, let's use the Pareto principle. Has anybody heard of the Pareto principle before? 80% of your problems come from 20% of your areas. So we looked at our costs, we did a Pareto, and we thought, right, where are our highest cost areas? Where are the areas that we could maybe use QI to target? 3 came out. Salary overpayments, thing called our mailing system and our printing, computer printing, and translation services, particularly important in East London as we have such a multicultural society. Many people speaking many different languages, so a major issue for us. So we thought these would be 3 potential areas we could work on, and we started to create projects solely focused around these 3 areas. And the approach that we took kind of looks like this. So you form a project team. You agree what you're trying to do. You try to understand the process. We started to do process maps or flow diagrams to understand what the process was and how we could improve it. You ask the team, what is going on? What do you think you'd need to do to improve this? We created a driver diagram. And then we started to think about what measures could we use to help us see if there's been an improvement. So we created a dashboard, a real-time dashboard, to help people trying out change ideas, see if there's a difference. Our approach was successful to an extent, but we also encountered quite a few barriers. So we thought, let's try to learn from this. Has anybody heard of a thing called a force field analysis? Show of hands. Developed by Kurt Lewin in the 1940s, and we thought we'd use this as an approach to try to understand what's driving our value-related QI work and what's restraining it and getting in the way. And certainly for us, a driving force is this thing called CRES, which just basically stands for cash savings we're having to make, 5% every year. There is definitely an appetite to sort of try to use this. You've already got a sense that as an organization, we're very committed to using QI methodology. It's a systematic method that can help us think things through. And we also found that those projects that had enough control over the system we were trying to improve did very, very well. But what we found got in the way was when you were picking projects that were kind of in part of a very, very big system where other stuff was going on, it became very, very difficult for them to have an impact. And what we also noticed, and this might be a similar thing for you guys, was people retrospectively tagging the QI name onto projects that had already been running for several years and saying, oh, let's QI that, when it had already started happening. So this got us thinking, what do we do next? So I'd like to describe to you PDSA number 2. And this really started with a conversation with Mr. Derek Feely. And he said to us, James, if you imagine this entire circle here is your organization, and you're thinking about delivering value for money or reducing costs, you're focusing 100% of your efforts on 5% of what's actually going on. Could you not think about applying that approach, and rather than just focusing on the 5%, think about the entire system? Because value, as you know, is not just about reducing cost. For me, it's about getting the most we can for every pound, dollar, shilling, whatever we spend for the patients and everybody else. So we took to our drawing boards again and we started again. And this time, our how was we're going to do 2 things. Number 1 is create projects or identify projects that remove waste from the system. But the important thing here, the balance measure needs to be the quality. Because when you remove the cost, what's the side effect? And the second thing was start to think about finding projects that really do focus in on increasing value. We used the same delivery structure, our value for money project board that seemed to work very well. The role of the chief financial officer, incredibly important there. And we used the exact same system. So then we thought, let's go on from here. What we really need to do is create a strategy. So we created this. And this is our value for money driver diagram, our first go. I'm not going to read through, you'll be glad to know, every single part of that. But what was important is we had 5 key primary drivers that we thought were really important to work on. And underneath that, well, there's a lot of information. So that's part 1, is that this is your strategy. Printed here is what we think we need to work on to increase value for money at ELFT. But you can take this further, because we're already doing work to increase value. So the interesting thing to do would be, if we know we've got almost 40 different things, some of these will be QI projects, some of them may not be QI projects, how do those interrelate with this new strategy we've set up? So we did that. We listed all our projects, we named them, and then we superimposed them onto our driver diagram. And I think this is a very useful exercise because it starts to help you to see where you're focusing your energy, but it also helps you to start to see where are your weak spots, or where are the areas that we just don't know anything about. And for example, for me, the yellow area at the bottom, looking at innovation and use of IT systems, it shows you that we're not really doing that much there. But you can go further than that again. Because the next thing you have to say is, there are many, many drivers here, but often what happens in a quality improvement project is you never know where to start. So many things to do at once. If we had to focus our attention anywhere, is there another system that we can use to help us single in? Has anybody ever used Covey's time management matrix before? It's a great system to help you understand where to focus your energy, what adds value, what doesn't add value. So we thought, let's use a version of this to help us understand where to go with our driver diagram. So we kind of used two ways to look. And what we did is we took every single secondary driver in our driver diagram, and we asked ourselves two questions. For each of those drivers, how much do we know about that? Is it something that we know everything about, every single fact, or is it a bit fluffy, that we kind of know we need to be doing something about it, but we don't actually know how that process plays out? So that was the first thing. And the second question we asked ourselves for each driver was, what do we think is the predicted impact? For that secondary driver, do you think it's going to have a massive impact, or could it have a medium impact or a slow impact? And what you can do is you can take each of the secondary drivers over here, and you can ask yourself that question for both, and then you can stick it into your matrix. So on the horizontal axis, we have on the left-hand side low value, and on the right-hand side high value, and on the vertical axis we have process not defined or process well defined, and you end up with something that looks like this. So the next question has to be, well, that's very nice, James, but what do I do with that? So I'm kind of thinking that most of you would figure out that it's probably not worth going for the far left-hand side areas, right? But I would like to see a show of hands. How many of you would go for the top right-hand side box? The processes are well-defined and they're high value. Show of hands. Good. How many of you would go for the bottom right-hand side box, where the process is not very well defined in its high value? Slightly more. And the common trap that people do is they go to the top right-hand side, because it's an area that they know, and it's an area they know has a big value. The key place to actually go is down here. Because if the processes and those drivers are a little bit fluffy, but you know they've got high impact, you'll get a bigger bang for your buck, so to speak, because only small changes you make there will give you big, big effects. If you go to the top right-hand side area, you'll put a lot of effort in, but you may only get an extra 1 or 2%. So we used that, and we then took that and superimposed that on our driver diagram. And lo and behold, it helps you now see our strategy, where our existing work is at the moment, but more importantly, where do we think we will get the biggest response if we choose to focus our work? And for me, the area, it might be different for you, but the area for me is the yellow area at the bottom, where we know it's a very, very high impact area, and we're not doing very much work on it. So this could be a way that you could use the QI approach to drive your overall approach. So for us, our next steps in our own journey for being a little bit more purposeful about targeting value for money through a series of, and a portfolio of projects, is to prioritize those which we've done, to build a measurement system around those key areas. For example, if we know innovation and IT is a very important area, it might be good sense to start to measure that a bit more and understand how those are interacting so we can start to work. And ultimately, we're trying to build here a portfolio of projects, not just one project, but a portfolio of projects that we can work on that will, over time, help us improve value for money. Amar.
Thanks, James. So what you've heard over the last 45 minutes or so is a way to articulate the multiple levels of return we're likely to see from quality improvement work. So keep coming back to these 6 levels in the way that you describe the benefits you're likely to see. If you are leading large-scale improvement efforts, think about how you can balance your portfolio of improvement work so that it covers all 6 levels of return on investment. If you want to know more about that in more detail, keep an eye out for this journal next month where we're going to be publishing this. Myself and the Chief Finance Officer will be publishing the data to back the framework here. And then, really importantly, as well as being able to articulate the benefit and the return we're likely to see from quality improvement, let's think together about now how do we move from looking at quality and looking at cost to now thinking about how do we improve value across the whole system. And you've heard James describe how we're now approaching this idea of a single value plan and building in a portfolio of projects and a learning system to help us improve value across our organization over time. So it leaves only for us to say thank you very much for joining us. I hope you've enjoyed the last talk, and do come and ask us questions at the end if you've anything of interest to ask us. Thanks very much, everyone.
Thank you, guys. Thank you.